Welcome, everybody. Let's wait a little bit while people are joining us. We're very excited. We had a lovely response to this webinar. We know that this is an extremely important topic and are happy that we have had a great response. My name is Jackie Eaton, and I work at the Saskatchewan Prevention Institute, and I am joined by my colleague, Megan Clark, who you'll see, and we are honored that Dr. Mahli Brindamour is joining us today. You will have noticed when you were joining the webinar that this session is being recorded, and we will be sharing the link to all registrants, as well as the YouTube recording will go on the Saskatchewan Prevention Institute's website. So that should be available within the next couple of days. It just takes us a couple of days to transfer that. Before we begin, I would like to do a land acknowledgement. So Dr. Brindamour, Megan, and myself are all joining the training today from Treaty 6 in the homeland of the Métis. We want to take time to pause and give thanks for all that this land means to each and every one of us. Megan and I, we both work for the Saskatchewan Prevention Institute, which provides services to Treaties 2, 4, 5, 6, 8, and 10. And we acknowledge the various ancestral territories of the Nehiyawak, Nahithawak, Nahinawak, Dene, Dakota, Lakota, Nakota, and Ananishpik, Nicoway peoples, and the homeland of the Métis. We acknowledge the treaties of these lands and reaffirm the responsibilities and commitments to healthy relationships between Indigenous and non-Indigenous peoples. At the Saskatchewan Prevention Institute, we are committed to understanding the history of colonialism and playing a positive role in the important process of truth and reconciliation. The Prevention Institute is a nonprofit provincial organization that has been in existence for more than 40 years. Our mandate is to help all children thrive through primary prevention and the promotion of well-being. And we believe that all children have the right to the best health possible. So I will now pass it on to Megan to introduce our speaker, and we will begin.
Thanks, Jackie. So yes, as Jackie said, we're very pleased and excited to have Dr. Brindamour here with us today. Dr. Brindamour is a pediatrician in Saskatoon. She's been a tuberculosis consultant with the Saskatchewan Tuberculosis Prevention and Control Program since 2021. She co-founded in 2017 Saskatoon's Refugee Engagement and Community Health, or REACH Clinic, where she works with refugee children. She also provides outreach clinics to the northern Saskatchewan communities of Crosse, Loche and Stony Rapids, as well as inpatient pediatric care at the Pattison Children's Hospital in Saskatoon. She is past president of the Canadian Pediatric Society Global Child and Youth Health Section and a member of the Caring for Kids New to Canada Task Force. And also, Dr. Brindamour is a member of our medical advisory committee here at the Prevention Institute and on our board. So thank you, Dr. Brindamour, very much for doing this, and I'll hand it over to you now.
Thank you so much, Megan and Jackie, for the introduction. It's such an honor to be here. And thank you, Jackie, for doing this beautiful land acknowledgement. In particular, when we're talking about tuberculosis, there is so much hurt and trauma that's been inflicted by colonizers and settlers to this land, and so much to do to undo and repair that pain and making sure that we're not continuing the trauma of the past. That specifically when we talk about tuberculosis, I'd like to spend a little bit more time on the land acknowledgement and saying why it's important. I will start sharing my screen right away. And then you can see my PowerPoint. I changed the title a little bit. The Pediatric Tuberculosis in Saskatchewan. Think about it, find it, or basically the importance of prevention, screening, and diagnosis. I have to say that I'm a little bit intimidated by this crowd. I certainly have nothing to teach about pediatric tuberculosis to Dr. Irvine. and all of the clinical tuberculosis nurses that are in attendance. So please feel free to answer questions with me at the end, or jump in to comment as you wish. So let's start about talking why is it important to talk about pediatric TB? Because it represents global human rights violation. There is no child in the world that should be infected with TB, that should be sick with tuberculosis, or that should die of this disease. And so it's considered globally, locally, a marker of injustice and inequity. Still very much an issue to tackle in Canada, even though we tend to forget it. Not necessarily, the tuberculosis nurses and myself, we think about that every minute of daytime hours. But even in the vastness of the health system, there is this impression that tuberculosis is a thing of the past, but it's still very much affecting people today and creating a lot of pain. And also, we know what to do about TB. It's preventable, it's treatable, and it's curable. I'll talk a little bit about the local situation with brief epi data and local statistics. I'll go on to talk about TB basics, and then I'll try to address frequently asked questions, and then hopefully we can have a little bit of a discussion about any questions or comments you might have about pediatric tuberculosis in Saskatchewan. So who is the most likely to get TB in Canada? So we know that inequities and injustice and social determinants of health will lead to people being disproportionately affected by tuberculosis. So in Canada, in Saskatchewan in particular, First Nations and Métis kids carry the brunt of tuberculosis disease. So again, another marker of the inequities that we live in every day. But I don't need to remind you of this because you all do this work. Children born outside of Canada and children who are refugees are in Canada the population that is most likely to get TB, but not in Saskatchewan. And then travelers as well, although that's much rarer. Now, when we talk about these PEDS TB numbers, what does it represent? We calculate the incidence of TB cases to give us an idea of how serious the problem of TB is and compare with different jurisdictions. So the children with TB who are reported to WHO and just epi data, even nationally, are those cases who are active tuberculosis cases, smear positive cases. Outside of those, there are all children who are diagnosed with TB, but who are diagnosed clinically based on symptoms, who maybe didn't get bacteriological confirmation, but are treated for TB. Then outside of that, we have to find the people with the children with TB who present to health services. There's lots of kids in the community who might take a long time to present. And then outside of that are the true number of all kids with TB. So you can see that this little circle in the blue is actually a much smaller number than the actual true number of children who live with tuberculosis in the world. So for Saskatchewan, what does that, so we'll go on to see what it represents for Saskatchewan. But in terms of when we think about one case of childhood tuberculosis, and for these data, childhood is interpreted between 0, so between birth, and 14 years old, which is a little bit different than the pediatric definition that we're used to when we deal with pediatrics at large. It is really tied to how much infectious cases there are around them. Because kids, and we'll go over that a little bit later, kids don't transmit tuberculosis. And so the only possibility is that they got it from an adult. So the very fact that we have a child with TB means that there is an adult somewhere who's contagious. And then the infectiousness of those adults is also tied to the availability of health services and the likelihood of these adults to recognize their symptoms, seek care, get treated, and all of the barriers that go along with that. And then, of course, this likelihood is then tied to the determinant level factors: poverty, First Nation status, housing, systemic racism, etc. So these are the most recent data we have, taking into account that the 2023 data are preliminary, and also that they don't include, for example, the data of this past week where we diagnosed several new cases. So it might look like a decrease, but those are not the final numbers. So if you compare the incidence across Canada and across the world, so Canada is considered a low incidence country, so meaning about 10 active cases per 100,000 people. And then the high incidence definition is 100 over this 100,000 people. So in Saskatchewan, you can see on that map, there's been a slow decline of the number of active cases until about 2019. And then in 2019, something happened, which was the COVID pandemic. And then since then, it's been increasing like something we've never seen before. So on the rise since 2020, and the rise isn't over. Now the rise in 2022, which is the last year that we have data for, we calculated that the incidence was 8.1 per 100,000, but that's Saskatchewan as a whole. But if you look at First Nation reserves in Saskatchewan, that number rises to 189 per 100,000. But again, those include also reserves in the south, where there isn't a lot of tuberculosis. And those are all reserves across the province. So if we look at tiny Saskatchewan communities where outbreaks of tuberculosis have been declared, these rates are upwards of 500. And we're talking about tiny, tiny communities. So you can imagine how these numbers have been impossibly devastating to these communities. And in addition to that, the numbers that we look at in Canada, this low incidence of 5.2, this low incidence in Saskatchewan of 8.2, they don't tell the true story. Because really, people who carry the brunt of the disease live in these tiny communities with rates that compare to the worst rates in the world. For example, South Africa and Lesotho have the highest rates of TB incidence in the world, and those are between 500 and 600. In terms of pediatrics, you can see here the numbers over the past 2 years. When we talk about outbreaks in other jurisdictions in Canada, it's very unusual to see that high of a number of children. In the outbreak areas that we had in Saskatchewan in the past 2 to 3 years, around 40 to 50% of these cases were pediatrics, so they're highly unusual numbers, which makes Saskatchewan a bit special when it comes to thinking about solutions. But really, it's not by chance that Saskatchewan has the highest rates of pediatric tuberculosis in Canada, within the provinces, because that's not accounting for Nunavut. But I'm sure Saskatchewan will do its best to surpass these rates as well. But Saskatchewan also has the highest rates of childhood poverty in Canada. And we're now seeing the worst outbreaks of tuberculosis, of congenital syphilis, of perinatal transmission of HIV. And this is not by chance, because we know that infectious disease is transmission and poverty, that infectious disease transmission and oppression go hand in hand. And as usual, in times of societal stress, would it be when it comes to the social determinants of health, such as poverty or even environmental catastrophes or war, in these times where societal stress is high, children are neglected and suffer. We know this. And in particular, when the inequities and injustices are so deep, tuberculosis is just the tip of the immense inequity iceberg. children who are diagnosed with TB in our province are those who live in poverty, or those who live in crowded housing and suffer from malnutrition. And not only is TB caused by this burden of injustice, but it also is adding to the burden that they carry. So now we will go into a little bit more of a clinical discussion, which is perhaps a little bit less depressing. And that's talking about the continuum of TB disease. We used to understand, and I say like maybe 2 decades ago, we used to understand tuberculosis infection as the umbrella that is tuberculosis infection, and then you either go on to develop latent or the sleepy TB kind or the active TB disease. But now we have recognized that this is more of a continuum. And in the middle, we're not quite sure what holds. But to make things a little bit clearer for the purpose of this presentation, basically, TB infection occurs when someone is infected by TB and the TB bacilla is in the body. But sometimes, most of the time, the immune system is able to keep this infection in check. So it prevents the replication of the bacilla. It doesn't create symptoms. It can't spread from person to person. And it doesn't create changes on imaging. So it really just is an infection, but without anything else. However, it can evolve to active disease, where now the immune system hasn't been able to keep the infection in check. The bacilli is replicating, and this creates symptoms, changes on imaging, and the possibility of transmission. In between these two, there is the continuum where we're not quite sure where people start being infectious. And also, could they, for example, vacillate between these two, be a bit in the middle, revert to latent, then something happened, develop active, etc. So these are areas of research that are fascinating, especially in terms of pediatric TB, because this is tied to the infectious load of adults around them. Now, why do we freak out so much about pediatric tuberculosis? It's because of this table. So in adults, and I would even argue, like even adults with suppressed immune system or living with HIV, TB evolves slowly. It's a slow-growing organism. We have time to diagnose it usually. It can evolve over years. But in kids, the situation is very different. So out of all the kids who will be infected with TB, if they're less than 12 months, there is 50% of these kids who will go on and develop active disease, so with symptoms, life-threatening illness. And of those kids who will develop active disease, almost a third will develop the severe form of active tuberculosis, which is miliary disease, so disseminated TB, or TB meningitis. This risk decreases over time, but all kids less than 5 are a lot more at risk to develop active disease compared to older adults. There's 2 peaks of risk period in pediatrics, less than 5 and teenagers. Probably related to issues of growth, etc. But teenagers have a little bit higher likelihood than, say, school children to develop active TB, and a bit higher than older adults as well. But really what we're trying to prevent is disseminated TB, TB meningitis in babies. So I know there's lots of people from the TB program here, but when I started this work in TB, I was impressed by the TB manager who would say, a positive TST in a baby needs to be dealt with in a matter of hours, which is still what I think, because this, not what I think still, but she convinced me, because this is what we're trying to prevent. So I'd rather be wrong and have a child not have TB in the end than risk the chance of missing it. Now, how do we find latent TB? There is a few ways. And So we do screening when we know what to do about the results. So TB is perfect for that because we have a way to treat it, we have a way to cure it, and we know how to react to a positive screening test. Now, the question when to do screening, the pediatric residents and the medical students who work with me will say always and in all circumstances, because that's what I tend to try to brainwash them with, but we can try to be a little bit more specific. So with any risk factors at all, a screening test is a good idea. And then there are certain risk factors, for example, being on a medication that suppresses the immune system, living with HIV, people with recurrent contacts, where the testing should be done routinely on a yearly or every X months basis. We have two ways of finding about TB infection. The most traditional way is the tuberculosis skin test. And then the more recent way, which is a blood test called IGRA. Now, the IGRA is validated over age 2, but there are newer studies that tell us that we could actually use it for everyone over 6 months of age. The TST can be done in everyone. The TST has its benefit. For example, it's nice to document the timing of conversion from a TST of 0 millimeters or non-reactive to a positive TST, because we know that the timing after conversion of that TST is linked to a higher likelihood of developing active TB. But it also requires a second visit. It requires some learning from the people doing the test. So it's not a perfect test. Now, the issue with the BCG, which is the vaccination against tuberculosis that used to be given in Canada, we stopped a long time ago. In Saskatchewan, we stopped in the early 2010s, around 2012. Before that, the uptake was fairly low. But there is this thinking in the healthcare system that the BCG will influence results of TSTs and results of IGRAs as well. What I always go with is the saying that a positive TST is a positive TST regardless of previous BCG vaccination. So the BCG vaccination will add kind of a layer or a puzzle piece to your interpretation of your test, knowing that in particular for people who received the BCG within the past year, it might give you a slightly false positive TST. However, one should never ignore a positive TST, even though this person was previously vaccinated with BCG. That's less important for IGRAs, but there's still perhaps a little bit of a link, less so than TST, however. These tests can be done anywhere. The TSTs can be done anywhere by public health, and anybody can request it, or people can kind of ask for a TST in public health offices where vaccinations are given. The IGRAs are only available in certain locations in the province. So in hospitals in Saskatoon, the community clinic in Saskatoon, the community clinic in PA, and the community clinic in Regina. So they're a little bit more difficult to access and a little bit more expensive as well, but quite a useful test when it's needed. So then again, how to choose between an IGRA and a TST, I won't spend much more time on this. I tend to favor the IGRAs when I can get them and when I don't need repeated testing because of that issue of not needing a repeated visit, especially in the context of the refugee clinic, for example, where often people have transportation barrier or it's hard to bring them back. The IGRA is very handy. But also expensive, so we have to think about that. Now, what do we do with the results of these screening tests? Again, they're only a piece of the puzzle and are only a marker of infection. So basically what it means is that they are only useful if they're positive. And a positive TST, a positive IGRA, only means infection. It doesn't differentiate between latent TB and active TB. And certainly there is no role in these screening tests to diagnose active TB disease. And For example, when we get negative tests, I often hear, oh, you know, the agar was negative, TB has been ruled out. That is a trap in which we should not fall. And that is because it relates to the way the immune system reacts to tuberculosis. So if one has a strong immune system and is able to suppress the tuberculosis within their body, then usually it means that if they do have a TB infection, their test will be positive. However, active TB means that the immune system has been overwhelmed by the bacilla replicating in the body. And so at times, which can be up to 30 to 40% of cases, active cases of tuberculosis will have negative screening tests. So again, it is only helpful in diagnosing latent infection and is only a marker of infection. Sometimes, rarely, in cases where it's very important to obtain all possible information and the diagnosis is unclear, which is often the case in kids where bacteriological samples are difficult to get, sometimes I will ask for both a NIGRA and a TST, which again will add to the puzzle pieces, but it's not necessarily something that we do routinely. Now, active tuberculosis, so the disease of tuberculosis in pediatrics, is a diagnostic challenge. And if people, often what I tell residents, if you can remember one thing about pediatric TB is it doesn't follow any rules. It can present almost like anything. It can affect any organ, and it's hard to find, it's sneaky, and ultimately we often miss it until kids are very sick and the diagnosis becomes clearer. Oftentimes, the symptoms will be very subtle. It happens that in cases of active TB, there will be no symptoms at all, and the chest X-ray will be normal, yet it is still active disease, especially in kids less than 5 years old, and especially in babies. Fortunately, most of the kids that we diagnose with TB are diagnosed or found because of contact tracing, because we have a good way of finding cases who have been in contact with adults who were infectious. So that's the link that we often talk about. However, sometimes our system doesn't work as well, and kids present with symptoms. Every one of these kids who present with symptoms and hasn't been part of a contact investigation should be considered a sentinel event. And we should find who in the community around that child is transmitted TB. And in my mind, I also think that maybe you won't be popular in saying that, but every child with active tuberculosis is a failure of the system. Not only of the contact investigation, but of the system that we all live in. Now, for the typical symptoms, the classic symptoms of weight loss, fatigue, night sweats, cough, the TB, the classic B symptoms, they're often not present in kids. Even the cough can be like on and off, subtle, barely there, and any respiratory symptoms, wheeze, stridor, shortness of breath, can be tuberculosis in children. And so this is due to the low burden of bacilla in active TB. So a very small number of TB organisms can make children very sick. And so if caught early, they will have not very many symptoms and imaging won't be all that bad. So so linking the symptoms, the imaging, and the epi-link will be what will help us in diagnosing cases. In kids, as an adult, it can present in three ways. So primary complex, so people get infected with TB, become sick right away. Usually this is pulmonary. Usually they're mildly symptomatic, sometimes asymptomatic. So this one is hard to diagnose in kids. Or it can present as reactivation. So people get infected with TB, it goes dormant, and then it gets reactivated later for whatever reason. Then in that phase, it can affect whatever organ, eyes, ears, anywhere. The most common pulmonary presentation in kids is lymphadenitis, in particular cervical. Osteomyelitis, so the well-known Pott's disease, in particular in the spine. Meningitis, abdominal. If you have TB in more than 2 sites, or in 2 or more sites, then it is considered disseminated or miliary. And then you could also have a reinfection or a relapse. So having had treated TB and then being exposed again, and then developing active TB again, or relapsing for a previously treated TB. And for some reason that I think are still being explored, this occurs a lot in Saskatchewan. So even children would have been treated for a very severe form of TB 3 years ago. So in our minds, we say, well, they had it, they were treated, they're probably protected, and now they're coughing and pneumonia doesn't go away. Most definitely, that can also be TB. So this is just for reference in terms of what symptoms will go with what sites involvement. And that can be true for older kids, but again, babies can just present as whatever, a little bit of fever, a little bit of poor feeding, a little bit of not great weight gain, and can be any of these presentations. Now, an important rule is that if someone gets diagnosed with extrapulmonary TB, we should always look very carefully for pulmonary TB, as most of the time, extrapulmonary TB will come with a form of pulmonary TB as well. Although, in particular, in cases of cervical adenitis, can occur independently. It's important also to reassess the potential for dissemination within the treatment. It does happen where you realize later in your treatment that, oh, we might have other sites that have been infected. And that will also influence the duration of treatment. So always to keep that in mind, even when kids have been diagnosed, say, with bacterial confirmation. It's very difficult to find active TB. In adults, we do sputum. Sputum sample is very good. We can trust it. If it's negative, it's probably means that it's negative. There are certain exceptions to that, but usually it's a pretty good test. In kids, there are no rules. It's often very difficult to obtain sputum. It's difficult to obtain samples from other sites, but it's important both for contact tracing and treatment, prognosis, to know and try to get bacterial confirmation if at all possible. But in the end, it occurs very often that it can be done. And so again, the epilink and the symptoms and the imaging will be the key to the puzzle pieces and the answer and decision if we are treating for active TB or not. The younger the baby, the harder it is to find it. And you can also imagine that obtaining sputum in kids is quite challenging, as they don't cough on command. You can ask a 15-year-old to please cough and then spit in the cup, and you can explain that, but a toddler is not going to want to listen to you. There are a few ways that we can go around with that. The newer guidelines from 2022 do advise induced sputum in babies over 6 months old, and it used to be reserved for older people, but it works quite well if you train the people who are going to obtain it well also. So with suction devices, 3% saline nebulization, it is often possible to obtain good samples in babies with induced sputum. But if that's not possible, then usually we do gastric washings. But the yield of those and the false negative results are much, much higher in gastric washing and all non-respiratory samples. This is, again, to give you an idea. You don't need to look to the details of that, but every sample that we take, every test that we do, there is no one test that will be able to rule out active disease. If there is an epilink, symptoms, and imaging that's compatible and no alternate explanation, it's not really possible for us to say, I am 100% sure that this is not tuberculosis. So it's always a discussion and a puzzle that we put together. So again, coming back to the diagnostic triad, I thought the most recent TB guidelines are even a little bit poetic when they talk about tuberculosis, because they talk about this triad. So based on the clinical case definition, it will rely on positive screening tests, abnormal chest X-ray or physical examination, and then the discovery of an epilink. And then they go on to say, and then some of these cases might also be symptomatic. Which speaks to the difficulty of diagnosing pediatric TB cases, even for simple pulmonary TB. But what I would say too is that it's okay to follow kids closely, especially if the initial evaluation showed a kid who was eating okay, who was stable, who was living in an environment where follow-up was possible, and then see how the imaging evolves and see if eventually we could be more certain of the diagnosis. But it will be always better to, treat a baby as active TB to prevent devastating outcomes such as meningitis or death, rather than missing it. Okay, so now to finish up when to think about TB or the active TB peace challenge, we need to think about it all the time, of course, but we can be a little bit more specific. So when to think about TB? Of course, the epilink and contact investigations. All of these kids who are part of contact investigations are potential active cases. When things don't make sense, when infections that were thought to be classic, especially pneumonias, joint infection, bone infection, meningitis, don't improve, then TB should pop up at the back of our minds. Any abscesses or solid tumors. I had a couple kids who were diagnosed as Crohn's disease, and then the pathology showed AFB and eventually was confirmed tuberculosis. And this is good news because no one wants to live with Crohn's disease. It's difficult to treat. It's a chronic condition, but TB, we know what to do. And when things don't make sense, which is often in pediatrics. Now, a few words on isolation, because this is a question that I hear a lot, both from trainees and when I'm on call, is when to isolate. For kids, it's easy. So up until age 10 to 12, depending on their size. So certainly for toddlers, certainly for babies, for most of school-age kids, they cannot transmit TB. They're not able to mount the coughing pressure to disseminate the bacilla in the air for it to be airborne. So they don't need to be on airborne precaution. Unless, of course, they're intubated or AGMPs are done. But again, they're probably much less infectious than their adult counterparts. And then for adults, I also have to remind people often that the only forms of TB that are infectious are pulmonary and laryngeal, which is very rare. But if it's isolated TB meningitis, no airborne precaution. If it's a history of cervical adenitis 5 years ago, no airborne precaution. But it's hard to dismantle this impression that TB equals airborne precaution. Now, sometimes in pediatrics, we will use airborne precaution if parents or caregivers have not been screened yet. But again, kids are often diagnosed as part of a contact investigations where we will know the status of household contacts, especially their caregivers. So it's rare that airborne precautions are necessary in pediatrics, but it does happen. This is more for people to have as an addendum to look at if they're interested, but what happens when we get a positive screening test and what next steps should be done for evaluation. Now, we don't have a good way to answer questions, but I thought that I would give a few interesting images to show you how there is great variation in how we diagnosed TB. And so the first X-ray is an X-ray of a 3-year-old with a right upper lobe cavitation, which we almost never see in pediatric tuberculosis. It's really rare that they present with these classic adult features. The second X-ray looks like a potential pneumonia and whiteout. The second one has like these streaks that are a little subtle. And the fourth one Does it have a mediastinal mass? Is it mediastinal adenopathies? So I often ask residents and trainees, which one do you think is TB? And I know it's hard to answer on a webinar, so this one, whoops, and number 3, but I think I erased my arrow when I was preparing the talk. So the first one usually is not TB. If it looks like this in a 3-year-old, there are many other causes of cavitation in the lungs in pediatrics. So it's rare that we see this, but this one turned out to be TB. The second one was a community-acquired pneumonia that improved on antibiotics and had no risk factors. The third one was, in fact, tuberculosis, and we confirmed it with gastric washings. So you can see these findings are subtle. This is not necessarily a chest X-ray where I would have been like, so obvious. Of course, let's test too. But this kid was part of a contact investigation and had lingering symptoms, and we were not quite sure, and their TSC was positive, but not very much. And so in the end, we did gastric washing and they were positive. And the fourth one, when I saw it, I was like, oh my God, this is horrible. He had mediastinal adenopathies. In the end, we did lots of investigations. TSC was negative. I think we did a CT chest on that one, and it was his thymus. So thymus can look quite odd in children. Again, not to be confused with adenopathies. But don't blame thymus for adenopathies either. Okay. This is a slide that I added recently because I like to talk about these things, is TB in pop cultures, or in pop culture, not the cultures that we use in the lab. There are a few great movies that describe the experience of patients having TB. The Necessities of Life is a joint movie that was done between Quebec, Nunavut, and Ontario, I want to say, or another province. And is very good. Map of the Human Heart also, but has been done in the 1990s, I think, so it's a little older. And then for books, people who like to read on TB, this is a little bit more nerdy, but it's a very good book. Is by Tracy Kidder, called Mountains Beyond Mountains. It's a book we talk a lot about in the TB department, and that we like someone's reading it and it's so good, and then they give it to 2 people, and this is how we disperse this book. And there's a movie that's been done about Paul Farmer and Partners in Health, which is called Bending the Arc, which sadly is not available on Netflix anymore. And then, of course, in classic literature, Les Miserables, Anna Karenina, La Dame aux Camélias, all of those novels have characters who have been deeply affected by tuberculosis. And I find, having read those novels when I was in high school and now working in this context, I find interesting to reflect on the meaning of tuberculosis in literature. So to wrap up, and hopefully we'll have a bit of time for questions, it's important to talk about TB. It's a very important, very present problem in Canada, in particular in Saskatchewan. And for me, as a healthcare worker, but also as a settler and as a descendant of immigrants, I feel personally responsible for fixing this disparity that is our doing. Because I've alluded to that a few times during this talk, is that we know what to do. We know how to fix this. We know what needs to be done to stop people from contracting tuberculosis. TB is preventable, it's treatable, and it's curable. So why is it that we still have children in our province dying of tuberculosis? And this is the take-home message for you. Why? And what can we do about it? And how are we going to work together to stop pediatric TB in Saskatchewan, in Canada, and in the world? If you want to learn more, these are interesting websites to look at. Our very own Dr. Irvine wrote a pediatric a CPS statement on tuberculosis a few years ago. I would invite you to read it. And I am, of course, always available for questions, and so is everyone at TB Control. And I would be happy to take questions.
Thank you very much, Molly. I'm just taking a look in the Q&A box and there isn't any questions in there. So if people have questions, please put them into the Q&A box and we will read them out. That was quite overwhelming for those of us that weren't really fully aware of the depth of the problem. No question. Oh, there's something in the chat. Let's see what's, there's thank yous.
Thanks, Andrea. So are you?
Oh, there's a question. Can you please clarify what you had mentioned around risk of TB in the teenage group?
Yeah, of course. So that's just looked at the different riskier period according to age. So youth and children as a group are at increased risk compared to adults, but within that group, less than 1-year-olds are the most at risk. And then after that, it's all kids less than 5. Then the risk decreases a little bit, but it's still higher than in adults. And then that risk increases again a little bit, but it's a bit lower than the babies, but higher than the school-age children. Don't know if it makes sense.
I think that's good. We'll see if anything else comes up. There's more thank yous.
Thank you. I mean, I feel like it's so, you know, I could thank Dr. Khan and Tina for all their work as well, you know.
Right. It's a team effort, but I think they appreciate you being the one to stand up and speak about it. They say you presented excellent. Yes, she just wanted to make sure. So that was a good answer. Thank you. And I'm just checking to see if anything's showing up in the Q&A, but no.
Oh yeah, and there is a advertisement for the next webinar, which will be sure to be interesting. What's Hot in Pediatric Infectious Diseases by my colleague, Dr. Athena McConnell. Sadly, I will miss her talk, but I'm sure she will have loads to talk about.
Right, thank you. And I'll just say now, while we're waiting to see if anyone else wants to put up any more questions, that when you close out of the webinar, a box will pop up inviting you to complete an evaluation. And we appreciate it when people do that because it helps to inform future webinars as well. So please take the time to do that. And as Jackie mentioned, it'll take us a few days to get the recording of this webinar available, but when it is, it will get sent out to those who had registered for the webinar and be available through our website as well. And at that time, evaluation will be sent out for people to complete if they weren't able to do it at the end of this webinar. Right, and the suggestion that there be CMEs available. So we weren't able to do that for this, but thank you for the suggestion. I believe that you're able to apply for CME if you indicate that you've attended something like this.
Yeah, there's not the non-accredited CME category.
Thank you, yeah. And Dr. Khan also said education of parents and families is very important for our Indigenous population. So that's a good question is, do you have any suggestions of how we could do that?
Yeah, I think it is important, but I also find that, in fact, people are very well versed in tuberculosis because they've had family members affected, because their grandparents have been in the sanatorium, and that the difficult part is undoing the stigma that's attached to tuberculosis. People don't want to be found. They're afraid that they will be forced to do things, and that they will be mistreated, and with reason, because people were in the past. So I find that piece to be difficult. In terms of education, you know, we could always do more education. But I don't know if it's the highest mountain to climb.
But that stigma, that's interesting.
Yeah. In terms of how to do education, well, there's all sorts of ways that could be done, right? You could go talk to schools. We could there are lots of school screening projects that are occurring in certain communities. So take the advantage of that to provide education to people. But another thing that's important in TB is that the treatment is, you know, it works well, but it's daunting, and it takes a lot out of people. It takes a lot out of their lives. It's long. There's side effects. They hear about us all the time. They have to take the treatment, and the piece on how to make that better for people is also important. You know, we use incentives sometimes, but often that's not enough for the toll that it takes on our lives.
Okay.
And then Dr. Irvine is saying, are there any particular recommendations on the timing of immunizations and doing a TST? So if, you know, I have to review those all the time, because I always think like, do opportunistic care and do TST when people show up at your doorstep. And I think that approach has to be done for immunizations as well. But I think if we want to follow the science, there is a little bit of a limitation depending on like the live vaccines and TST timing, but I can't remember what it is. Again, because it's such like just a piece of the puzzle, I would be tempted to be like, disregard. I can't believe that I'm saying this in front of public health nurses and in public, but you know, yeah. If you have the chance, I think do a TST, and then, you know, to be fair, we could read the guidelines also.
Andrea says,
thank you.
Yeah,
on
4 weeks.
On the same day. They're your opportunistic care. So immunize, TST.
So I'm not seeing any other questions. Anything else you'd like to add?
No, thank you so much for the chance to coming and speaking to all of you.
Yes, thank you very much for giving this presentation. It's a very important topic that those of us who aren't fully in the know definitely need to know more about. Thank you.
Yes, thank you very much, Dr. Brindamour. That was wonderful. So as Megan said, we will be sending out the recording in the next couple of days. And thank you all for joining us this afternoon. Have a wonderful day.